Welcome to today's webinar on Leadership Development, Action-Oriented Leadership for Patient-Centered Health Home Teams. Action-oriented leadership is a term that references this unique position of your patient-centered health home team. These teams are not merely an advisory group, but this is the group that will lead your transformation into a patient-centered health home. They will be the ones responsible for the do of your action plan, from drafting policies and procedures to implementing and training on workflows. Your team will be responsible for making things happen. Most likely your team will be made up of your organization's seasoned leaders. Today's webinar focuses on some of the unique challenges they may face. Most likely your team members will already have full plates, so we're going to review some tips and tricks to help increase efficiency and ensure that they have a clear action plan. Your team members are also very passionate about their role in your organization, their program, and their staff. This can be a challenge when trying to reach organizational-wide consensus. So the second half of the webinar focuses on working together, communication skills, and conflict resolution. Often when an organization gets a new grant or project, they hire new staff to lead that project. However, while hiring a coach to walk you through the patient-centered health home process is highly recommended, the actual work has to be done by those who are familiar with your organization, the current workflows, and the policy. The people needing to do the work for PCHH are probably the people who are the busiest. In this section, we will discuss ways to help these team members improve their effectiveness and manage their competing priorities, along with developing strong action plans to help you clarify the work at hand. Improving effectiveness. This topic seems a little like dieting to me. If there really was an easy fix, wouldn't we all do it and be working 20 hours a week? However, in nonprofits, it seems like the more you get done, the more there is to do. Ahead, we will review some quick reminders, things that you probably all know, but yet sometimes we get so busy we forget to follow them. When leading your PCHH team, you may want to share these little tips and reminders with the team, just as a way of kind of acknowledging the realization that you know they're going to be taking on more work and trying to fit this into their already busy schedules. One of the tips here that's so close to my heart is knowing and planning for your work style. My coworkers always joke that I don't get anything done before lunch, and my work style really is to come in and check email and grab some coffee and say hi to everyone in the office. I'm definitely more productive after lunchtime. So I try and schedule meetings for that early morning period so that I can save my afternoons for those projects that really take my attention and undivided attention and time to take care of. And that way I crank through them in the afternoon and I spend my mornings in a little bit more laid back of an atmosphere, getting to know, working on projects in a team environment. One of the themes throughout this presentation is going to be taking time to plan and think through decisions. Really, this will save you time in the end. And you're going to face this with your patient-centered health home teams. The desire for the team to just make decisions, change the workflows, write the policies, and not go out and solicit the opinions of all your stakeholders. However, without the planning and thinking through of decisions, you may not get the results that you were expecting. We need to make sure we're focusing on results, not just cranking through some tasks. Additionally, not getting feedback from your stakeholders, as we'll discuss later, really sets the groundwork for having some serious problems with conflict. Most management seminars I've been to talk about the tip of checking emails in blocks of time. And admittedly, it's really hard to get used to. But I notice that whenever I leave my email open, I'm constantly drifting away from whatever I'm working on to read messages. And then it takes me extra time to get my focus back on the project at hand. Plus, I tend to want to respond right away to all my messages, and sometimes responding before I have all the information. That just wastes everybody time. The other tip of asking if you really need to respond refers to the dreaded reply to all. When an admin sends out a meeting notice, I don't need to see 50 responses thanking her for scheduling that for us. A great tip on mass emails is to let them sit a while before you respond. Think about how many times you've been in the middle of drafting a response when someone replies with the exact message you were about to send. It definitely saves time to let others do that work. This do not disturb was a topic of discussion among the patient-centered health home coaches. As organization leaders, it can be nearly impossible to get uninterrupted times. However, I do appreciate when someone tells me, I'm in the middle of X, can we talk next week? It's just awful to walk into someone's office and start having a discussion with them when they're not focused or they're trying to rush you out the door. Or even worse, when they realize, oh yes, I need to engage in this, but I can't now, so can you come back in an hour? And again, you have to repeat everything you just said. Telling me up front, I'm busy with this and let me focus on you in an hour definitely is better. Scheduling regular meetings. I really love to work in a collaborative environment. I prefer to walk down a hall and pop into someone's office and try and engage in a conversation. And again, like above, you want to know that person is ready to engage with you as well. So scheduling, just like emails, the more time you have to think about things, the more focused your questions and opinions can become. Plus, it saves the interrupting of someone else or talking to them when they're not focused on you. Finally, if it's an especially hot topic, running down the hall to complain is never an effective way of handling it, and you definitely need to take the time to cool down. As a leadership member, the last thing you might be willing to do or consider doing is closing your doors or hanging a sign that says do not disturb. But as you're starting this patient-centered health home process, you really need to make sure that your team members understand and have the permission to have that uninterrupted time, that they feel comfortable closing their door. While they're afraid it might give the impression you're bothering me, it's sometimes just necessary. A beneficial way of handling pending deadlines is definitely to work from home if possible. That way nobody feels shut out, but yet you're able to get the work done that you needed to do. When discussing managing priorities, it's important that your team respects each other's times as well. And so this is why we put in a topic about preparing your agendas. Distributing the agendas in advance allow for people to be prepared for the meeting. In your handout, you have a couple of sample agendas for you. This first one is for an EHR project meeting. One of the unique things about this agenda is the next steps column. We added that column in lieu of distributing minutes from every meeting. It takes somebody a lot of time to take those minutes, type them up into something other people can read and is appropriate, and distribute them. And we found that they just weren't getting read. And the next steps people were supposed to take were hidden in those agendas, and you would say, well, remember we talked about it at the meeting. Didn't you see it on page 42, paragraph 5 of the meeting minutes? So we decided to, instead of distributing meeting minutes, use our agendas for each meeting. We would put in our topics, who the lead was, and then we would put in the next steps that were determined at the previous meeting. The next agenda is a little bit different of an agenda. It's actually a coalition meeting agenda. And you'll see from the purpose of the meeting, we're going to review and learn, which pretty much meant we weren't going to accomplish anything. We weren't going to make any decisions. No actions were going to be taken. The unique piece of this agenda is the fact that there's a time frame on it. And each person who was giving a presentation was limited to a specific time frame. And I would strongly encourage that. If during your meetings you are going to have people give presentations, giving them a time frame of 10 minutes and making them stick to it and knowing exactly when that is on the agenda tends to be very helpful. The last sample agenda is actually a patient-centered health home meeting agenda. Again, similar to the first agenda, they have their notes and action items in that last column. What's unique about this is they also added a column for documents and a column for discussion. So for some situations, it might get a little busy to have all those items, but it really, again, can act as your minutes. The other great thing about this is you want people to be prepared for their meetings. So you want to make sure you send this out in advance and people have it and people know what their action items are because it's clearly laid out that you're supposed to email Wendy with questions or additional engine items to Stacy by close of business Monday, August 27th. You know that you're supposed to have the agenda with you. You're supposed to have your PCHH surveys with you, and you're supposed to have reviewed them. So everyone has the information at hand to be prepared for the next meeting. Having people wait to take action is a time waster for everyone. I've been in meetings where we couldn't get anything discussed or resolved because no one was prepared with their action items. And while everyone loves a short meeting, nobody wants to waste their time in a meeting that we didn't accomplish anything. So when someone commits to something or is responsible for providing an update, it needs to be done. You can't go into a meeting and have them say, oh, well, I'll do it next time. You definitely want to use some concrete examples of saying, what is the next step to get that done? When are you going to do it? And can we count on you for that? And then you add that to your agenda. And the last piece here that I just want to touch on is prohibit I-meetings. This has become a huge problem in organizations that everyone has their BlackBerries, their laptops, their iPhones, their iPads, their i-whatevers, and they're on them during meetings, and they're not paying attention to what's at hand in the meeting. At that point, it would be more efficient for them to be in their office focused on one thing than be at our meetings. And additionally, they waste everyone's time because it never fails that they need to be involved in something. They catch a piece of it out of the corner of their ear or someone asks them a question and they're not prepared to respond. So we absolutely support leaving the I tools at the door. One of the phrases we use at our meeting all the time is we need to have one meeting. Everyone needs to be engaged. And we eliminate those side conversations as well. And something really exciting coming about is using video conferencing. While everyone wants to be in the same room and it sounds so nice and friendly, the truth is we're not putting our arms around each other and giving big hugs at the end of our meeting. So doing it via video conferencing is definitely a reasonable way to do it, especially if you distribute the agenda, the items in advance, and everyone knows what they're expected to have. This next slide is really about making your teams accountable. As we talked about before, putting the next steps on your agenda, putting people's names next to it. I'm as guilty as anyone for agreeing to do something and then finding out, well, I really don't have time to do that, or I haven't gotten around to it. And I go into a meeting and they say, Amy, what's the status on XYZ? And I say, oh, well, I'm working on it, and I give a superficial update and make a little note on my pad. You really need to do this by the next meeting. I like these questions because they not only do they make you accountable, but they help that person who has the best of intentions. I never take something on intentionally saying, oh, I'm just not going to do it. But it helps them kind of flesh through getting to what they need to do and asking for that help that maybe they didn't realize they need. So can we count on you? Are you having difficulties? Who could help you? And somebody might even volunteer in a meeting and say, oh, well, you know what? If that's the next step, I can actually get that done for you. And so having them break down their projects and asking for that help helps increase accountability and will actually help take your team to action. So there are really only 24 hours in a day. So no matter how efficiently we manage our time, how wonderful of meetings we have, at some point, time is just going to run out. Something has to give, and we don't want it to be our patient-centered health home activities. So this next section is going to give us some reminders on how to get some things off of our plate to make time for the new items. Before we even start organizing our priorities, we do need to identify them. I know a lot of people keep their to-do lists in multiple locations. I have one page in my notebook from a meeting here that I need to do these 3 things, and then a different notebook with a different page with the different 3 things. And then somebody walks into my office and asks me to do X, Y, Z, and I start working on that, and I don't ever have an organized to-do list. So that's definitely the first step, is identifying what you need to do. As we talked about in the previous section, planning saves time. And organizing your priorities is a perfect example of this. And then we get into the triple D. Delete, delegate, and do. Once you have a list of what needs to be done, you can mark off things that you look at and go, this is great, but now just isn't the time. Yes, I want to do this, but it's not going to happen in the near future. I'm going to go ahead and delete it from my actual active to-do list. And then we have delegate, which we'll talk about next, how and when to do that. And then what's left? Well, just doing it. Some people are fantastic about delegating. In fact, some people seem to delegate all of their work, where other people just seem to can't let go and want to do everything themselves. as a leader, you definitely need to find a balance between that. So here are some tips when delegating is appropriate and how to do it. You need to remember that sometimes it may just seem easiest to do it yourself. It's quickest. The immediate benefit is you're just going to get it done. However, there are some long-term benefits to delegating. A, you can get employee development or employee buy-in to the project, which we'll talk about is critical to the success of our project. So under that opportunity for employee development is a way to get another person involved in the project who can be a champion for the project in the end. Are they going to feel good about themselves? Are they going to feel good about their job? And that time you spend training them in the beginning to do it, is it going to help them do it on a long-term basis and save you time in the end? So you can't delete and you can't delegate. Now we're left with the do. Prioritizing your to-do list. You've crossed off the things you couldn't do. You've delegated out a bunch of them, and now you have an active to-do list. I continue to use a handout from one of my very first professional conferences that I attended to keep my to-do list. It's called the 6 Most Important Things I Have to Do Today. And I'll admit there are times that 6 turns into 60. So determining what things I need to do today becomes a challenge. And this was just a fun little calculation to help you prioritize. Ranking things in order of importance and ranking things in order of urgency. Multiplying those together would give you your priority list. One of the key points here, though, is making sure you list your action steps. You need to break down your projects into the steps you need to take and list the most important steps, not projects. Listing gaining patient-centered health home recognition as one of the 6 most important things you have to do today is not going to be productive. In fact, you'll find if you're avoiding items on your to-do list, it could be because they aren't broken down into the small enough steps. So we've talked about making time for the new projects that are sure to come about as you begin your patient-centered health home transformation process. We're being efficient, planning time to plan, controlling distractions, and holding team members accountable. Now it's time to get things underway. This next section will give a brief overview of action planning, breaking those big projects into actionable items. Action planning is also a way to communicate what is expected to those who need to know. Fixing accountability on each of the action steps reduces the chances of delays or avoids in the pursuit of our objectives. I was recently at a workshop where a team had decided their action plan was lowering no-show rates. To this day, I don't know if that was their objectives, assumptions, inputs, or measures, and I'm pretty sure they didn't know either. They just knew that lower no-show rates was an important part of clinical management. Having a clear picture of what your objectives are, your desired outcomes, and what the steps to get there, and how to measure them if you reach your goals are critical to gaining the buy-in of your plan. PDSA's Plan, Do, Study, Act. This is a complex, in some levels, way of describing how you're going to map out your action plans. Obviously, the first step is to plan what you want to achieve. What outcomes are you looking for? With my no-show example, the outcome was probably to increase access to care. You decide on the end results you want, and then you work back from them to set up objectives, such as lower no-show rates, and plan the tasks or activities required to get those outcomes, such as making reminder phone calls, as well as the measurement. How many reminder phone calls were made, how many patients no-showed, what our third next available appointment looked like. The next step is do, part of our triple D. It's time to make it happen. Do the tasks and activities we planned for. And when it's done, we're going to study the outcomes. What actually happened? Did we get the results we planned for, expected, wanted, or different results? Were the results wanted or unwanted? If things didn't go as we planned, why not? And are things now better or worse or the same? If they're better, can they be further improved? If worse, why? And what should we do next? And if the same, why? And then the final part of the cycle is to take action, which is based on the results you got in your analysis. If the change was good, build it into your system. If things didn't work out well or you need further work, You might just refine the plan or part of it, or even start over again from the beginning, which takes you on to another stage of the cycle. Step 1, plan again, but this time with your new knowledge. The next slide breaks it down even more simply. With your inputs, how are we getting there? Our process, what are we changing? And our outcome, what is the effect of that change? One of the things I want to talk about when we're looking at our planning is understanding the variation of the data within our lives. Things happen. Maybe your plan was to do one thing and somebody was out sick and those things didn't get accomplished. And you need to be sure you're making good management decisions based on your measures and based on the outcomes of your measures. And when we're talking about system changes, we're just looking at a collection of processes that interact with each other. And sometimes it's difficult to predict how these processes will change with the QI projects. One of the examples I recently heard was about needing to leave earlier. And so you started by setting your alarm earlier, assuming that will get you up earlier and get you out the door earlier. However, I've set my alarm earlier in the morning and realized I had all this extra time and decided to do a load of laundry or make something for dinner quick. And I actually ended up leaving the house later because I misused that extra time that I had built into my day. So sometimes it's difficult to predict how when you make changes, they're going to affect your actual outcomes. So your inputs are the things that are going into your process of your system. For each major action, there's a milestone established. Likewise, for each task or activity within a major action, you must have a time frame and a person accountable for the activity. You're going to have two kinds of activities. You're going to have serial actions. A must be done before B, but you're also going to have things that multiple people can work on at the same time. Assumptions are frequently overlooked by the people planning the project. Think of assumptions as the external conditions that must exist for our project to be logic and valid. They are conditions over which you lack control or chooses not to take control, but they are going to affect your processes and your outcomes just as much as any of the inputs that you are intentionally managing or controlling. So you do have your choice. You need to identify them, you need to analyze them, and then you need to make a decision to act on them. Are you going to change your project design based on those? Are you going to add tasks, or are you going to do nothing and see what the outcome ends up being? Objectives. Usually I refer to objectives in the SMART format: specific, measurable, aggressive, reachable, and timely. Valid, verifiable, targeted, independent. Those are all ways to describe your objectives. I like this set of explanation, this specific definition, because it spells out action, which is appropriate for our action plan. But really, it comes down to what are we trying to accomplish? What are our outcomes? And you need to make sure you're effectively communicating the action plan, the objectives, and the outcomes, the hoped outcomes, to the participants, to help them encourage their ownership of this project. So who are we communicating this to? Well, we're engaging our stakeholders on this. Remember, people support what they help to create. So we kind of flash back to our discussion about delegating, and asking someone to get involved in the project engages them in it and has them take ownership. When you are looking at your patient-centered health home projects, don't forget about the patients. How are you going to engage everyone, not just leadership and the board, but your employees, from your providers to your reception staff, and build a consensus and commitment among all of your different partners, your dental program, your perinatal program, your primary care program, your behavioral health program. Everyone needs to have buy-in to this and at all levels. And then you also need to look at your patients. Outcomes should be qualities that have value for them. So let's review. If we start making phone calls to remind patients about appointments, our outcome in theory will be lower no-show rates. And lower no-show rates means patients aren't taking up multiple appointments for reschedules, and so we reach our goal with increased access. If inputs, then outcomes. If outcomes, then purpose. If purpose, then goal. I want to take a minute to talk a little bit about some different measures. Proxy measures are measures that point to outcomes that are difficult to assess. So for example, we want to have healthier patient population. Well, there's no true measure of healthiness. So we're going to use a proxy measure. We're going to measure things like lower BMI, LDLs, A1Cs, blood pressure. We're going to use proxy measures to determine if our patients are indeed actually healthier. The other measure are your process measures. Those track progress on your drivers and change. So you'd look at things like how many patients received a reminder phone call, and how many times you did the actions, or whether the actions done the way you expected them, versus the outcome, measuring the outcome and seeing if you actually made your goal. So now that we've freed up our schedules and put together our plans, it's time for everyone to work together. Let's talk about emotional intelligence. Emotional intelligence is going to allow us to maintain relationships with others as well as keep our actions under control. It helps to keep us motivated in adverse situations, reduce stress levels. It also enables us to communicate well and influence others without conflicts, which will be the last topic that we cover in this webinar. I think when I talk to teams working together, this is one of the biggest complaints, is the emotional interaction between the people on the team and how they're able to work together on a joint project. There are 4 skills with emotional intelligence. You can see that the top 2 skills are really more about you, your self-awareness and your social awareness. And the bottom 2 skills are more about how you interact with other people. Emotional intelligence is really about empathy, handling relationships, managing your emotions, and being self-aware. These attributes are critical for every manager, and they really are an important aspect of who we are as people. Knowing yourself and doing the most you can with what you have. It's definitely not about being perfect or having complete control of your emotions, but it's allowing your feelings to inform you and guide your behavior. So this first skill, self-awareness, is your ability to accurately perceive your own emotions in the moment and understand your tendencies across situations. When I'm in my room with this person, I always feel this way. When this topic comes up, it makes me feel X way. I'm very passionate about this because of X, Y, Z. A keen understanding of your tendencies is important. It's going to facilitate your ability to quickly make sense of your emotions and identify what you're feeling. The next piece, the self-management piece, is not only being aware, gosh, that always makes me really upset or really angry, or I get anxiety, I tend to shut down in this situation, but allows you to direct your behavior positively. What happens when you act or do not act. And it's dependent on your self-awareness and knowing how you're feeling. The social competence strategies focus on then how you behave with other people. Listening really is the most important thing you can do to build social awareness, and we'll talk a little bit about active listening in our section on communication. It also is really hard work. It requires a unique blend of self-management and multitasking, especially when you're in a difficult situation. Social awareness is your ability to pick up on emotions in other people and understand what is really going on with them. To develop your social awareness skill is pretty simple. All you have to do is pay attention to body language, tone and volume of voice, and speed of movement. And choose to do so and choose to be aware of other people's emotions. Sometimes it's difficult to say, oh, well, he was being, not acting in a manner I liked because of X, Y, Z. Bottom line was you didn't like how he was acting. So to recognize that and understand that. And then relationship management, use your awareness of both your own emotions and the other person's emotions to manage interactions successfully. This will help ensure that you have clear communications and effective handling of conflict. People who can manage relationships well are committed to their value of those relationships and are able to see the benefit in connecting with many different people, even those you're not fond of. There have been numerous books written about emotional intelligence. I specifically referenced the Emotional Intelligence Quick Book. But there's quizzes to do a self-assessment, and in your handouts you have a quiz. And I chose that specific quiz as a handout for this presentation because it talks about how each different strategy in the answer key relates to different situations as opposed to being a true self-assessment. So I really liked that you would gain an understanding of emotional intelligence. And then, of course, if you decide to continue to work on your emotional intelligence, there's other resources out there to help you identify your areas of strength and weakness. Patient-centered health home, fortunately, unfortunately, isn't a solo project. You're not going to be able to gain your transformation all by yourself. It relies heavily on a team. And hopefully you have an emotionally intelligent team. How does your group relate to one another in making decisions and responding to other groups in the organization? Increasing your emotional intelligence of your team can help them respond constructively in emotionally uncomfortable situations, and will help them influence one another in a positive manner. So as we review these skills for teams, you're looking at the ability to accurately perceive the emotions that influence the group, management, emotional management, being flexible, directing behavior in a positive direction, and managing emotions to motivate your efforts. And notice when emotions are playing a role in managing the team so that they can move forward. And then we, of course, have our internal and external relationship. Again, this comes into play when you're gaining the buy-in of your stakeholders. What is your ability to interact effectively with one another in order to respond well to difficult or challenging situations? Who's going to be the best person to go out and talk to providers who may be resistant to the change you're presenting? Or who's going to explain how to do something to your reception staff? Who's the best at making it look easier? Who's going to be the best to understand the concerns of the providers? And really, your internal and external relationship management is strengthened by the ability of each of your team members to practice social competence. A team can enhance its emotional perspective really by focusing on the bigger picture. If team members have opposing views, the group should discuss those views and ask, what are we overlooking? What angle haven't we heard or thought through? And how can we reach, the best answer for our organization as a whole? When things are uncertain, someone in the group should reinforce their confidence in the ability to succeed. And it's important to remember you're not going to be emotionally intelligent all of the time. Part of emotionally intelligent teams is learning about each other and helping the team interact positively in a variety of circumstances. While it would be fantastic to have emotionally intelligent organizations, reality is emotional intelligence is a process, one that some will be open to and ready to improve on, and some just will not, especially when we go even beyond the walls of our team into our actual organizations. So we're going to take a brief detour here to talk about change management. It's a way for you to use your internal emotional intelligence skills, your personal emotional intelligence skills, to help guide your organization through the patient-centered health home concept. The phrase change management is very common in management and articles. And Peter Drucker actually asked whether or not one can manage change at all or merely lead or facilitate its occurrence within our organization. Nevertheless, change management is the process by which an organization gets to its future state, its vision. We're changing all the time. While traditional planning processes, our action planning really talk about the steps on the journey. Change management is going to attempt to facilitate that journey. Therefore, creating change starts with a vision and empowering individuals to act as change agents to attain that vision. The empowered change management agents need plans that provide a total system approach realistic, and are future-oriented. I love this quote from Mark Twain. Change management is about being aware of the emotions of your stakeholders. People really want to feel good about themselves, and ideally people are able to take pride in their work, feel responsible for a job well done, feel that they are part of a high-quality enterprise, and feel that their time has significance. In some situations, people are going to invent strategies to help them feel better about themselves. These strategies involve getting some sense of control, belongingness, and significance out of their work. Therefore, your change initiatives unknowingly and definitely unintentionally threaten to cause the workers serious personal loss. Not surprisingly, those are going to be your workers who resist the change and do all they can to sabotage such change initiatives. And I've really seen this within my own organization, that people who are the strongest or the most committed to their role in our organization are the ones who are the most resistant to the change. They're the ones who think they do their job the best, and you should listen to how they do their job. And if we're going to implement a workflow across the organization, it should be the way they do it, because they're really good at it. And so getting them to change is a challenge, and getting them to change without allowing them to feel like they're involved in that change is nearly impossible. And so it's something you have to keep in mind as you're facilitating this change across your organization. So here are our 5 levels of change. Total resistance. They're being stubborn. They're denying the benefits, need of an item, process, or concept. And most of us have recently implemented electronic health records. So we remember those providers who've said, I'm going to quit if I have to use an electronic health record. We've been using, writing for years. I've been, handwriting my notes for years. There's never any reason to do this. The next level is the skepticism. They're willing to try, but they just don't think this is going to be good. They're the ones who are telling you, it's going to increase my workload, tenfold. It's, what if the system's going to go down? We're not going to be able to see patients. They're doubting the benefit and use of an item or process, and they're clinging to the past. Then they adapt and they move past their reluctance and they fully accept the item and that it can be, or process, and that it can be integrated into their professional life. Yes, we can use this, and yes, it's good, and no, it hasn't crashed, so I'll give you that. And then they shift and they open up to the what-if scenarios. They're still feeling a little uneasy or uncomfortable, but they're looking at, oh my gosh, what if there was a prescription drug recall, and the system will let me pull a list of everyone, who is on that, who I've prescribed that drug to. Oh, but I don't think it'll really work. And then we get to the total cohesiveness. When they are your change agent, they are your change enthusiasts. They're going out, they're telling the other providers about how exciting it is. They're doing presentations at your clinic about their new great EMR system. And I think when you're looking at change management, we can think about our EMR systems. And almost everyone, when they go live first with that practice management system. You're looking for that short-term win, building some change champions in there for you. Most of us were on electronic practice management system to begin with, and we brought in our new system and we said, oh, ta-da, and you knew deep down it was going to be successful. You had no doubt that this was going to turn on and that it really was going to be easy. And so you wanted to start with that so that you could get that short-term win. You've got your reception staff now all fired up about it. Maybe it does some cool things that helped improve their workflows, and they're excited about it. And so I think that as you think this through, that was a strategy we used and before we totally did the transformation of going to an EMR from paper charts. We built our team. We got the right people in place with the right emotional equipment. I know even in building our EMR team, we brought people on board who were skeptics. and got them down, let them look at it, had them play with it before we ever went live. We had the vision. We, without a doubt said we were going to increase productivity. This was going to be better for patients. Here was all the great things. And we communicated that. We involved as many people as possible, simply to make it appeal, respond to people's needs. We told our patients about it. We got our patients excited about it. We had flyers and signs and all of this fantastic stuff about all the great things that were going to come from our EMR. We empowered action. We enabled constructive feedback. We put Post-it boards up all over our offices. Tell us what's going wrong. Tell us what you'd like to see improved. Tell us if you're having any problems. We met and met and met and met and met so that people could express their concerns and feel like it was going on. We've already talked about the short-term wins. We didn't give up. We stuck to it. Determination. We said we're going to do this, and we're not going to say this is a bad product. We're not going to say this isn't going to work. We're going to stick to it. And we reinforced the value of our change. We weaved our change into our culture. If we get a new provider, I can tell you who comes on board and doesn't want to use the EMR, isn't trained on the EMR, wants to use a scribe, our culture in our clinic is very much, what are you doing? Why wouldn't you use the EMR? Oh, he doesn't use the EMR. We're ready for it. We use it as part of who we are as an organization. So we've talked a little bit about change management within your organization in regards to you're not going to get everyone to be emotionally intelligent. So those are some techniques you can take to move your team forward, move your organization forward in regards to accepting the change on a widespread level. Now we're going to turn back to talking about our teams, the emotional intelligence of our teams, the skills we've built with emotional intelligence and change management to enable us to communicate well and influence others without conflicts, which is what we're hoping to do. However, as you bring your teams together, each person, as we discussed in the beginning, are going to have differing opinions and priorities for the stakeholders that they're representing. So this final section is on conflict resolution. It's going to give you some communication tips to apply with your emotional intelligence to hopefully minimize conflict, and some resolution tips on what to do if there is conflict. As we talked about, one of the important skills of emotional intelligence is active listening. And the first piece of avoiding conflict is listening. Conflict often arises from simple misunderstandings or people not taking the time to actually hear and understand what the other person's view is. Active listening is going to focus on who you are listening to, and as the listener, you should be able to repeat back in your own words what they have said to their satisfaction. It doesn't mean you agree with what they said, but you really do understand what they're saying. And on your teams, this is going to be a critical piece to ensure differing opinions are heard and that they're processed by your team. We don't want things to just go by the wayside. We really need to make sure that everyone's opinion is heard, validated, considered. This next slide is about your responsibilities as a speaker and a listener. One of the flyers recently posted in my office was a big sign that said, think before you speak. And is it true? Is it helpful? Is it inspiring? Is it necessary? Is it kind? And while I think very little of my own personal communication meets all 5 of those requirements, it brings home to the point that we're doing more than just talking. When we're talking about our patient-centered health home teams, we're talking about the conversations that are taking place that really need to surround those actions. So the conversations that are taking place to make those actions happen, to make the decisions happening. It's not a we're going out to lunch and we're catching up on our day kind of communication. It's an important communication that we have responsibilities for. As we discussed earlier, meetings take time out of everyone's schedule, and we need to be sure that we're upholding our responsibilities of both communicator and listeners. Our messages are clear and specific, and the listeners truly understand what we're trying to communicate. As a listener, you listen with your eyes and your ears. You listen with the sensing of those around you, especially if you're working on emotional intelligence. And it's difficult to pick up whether others are agreeing or disagreeing with you, enjoying or not enjoying, and what's being presented. I know right away you can tell if I'm annoyed in a meeting. I ooze body language. I disagree, I think you're, I think that's a stupid idea, those type of things just kind of come out in my body language. And so it's easy to tell as a listener. But like emotional intelligence, it's important to know your audience listening style and how best to communicate with them. Prior to my career in healthcare, I worked for a bar association. And the lawyers I worked with tended to be very action-oriented listeners. They liked concise info. They wanted to jump ahead to the point. They would use questions to move to the next point. So basically, you would go into a meeting, you would start talking, and they would interrupt. They would want to jump ahead. They would ask questions. They'd want it as concise as possible to get to their point. And that's how I got used to talking. However, then I came into the healthcare field, and the people I worked with tended to be more content-oriented listeners. They wanted all of the information before they made a decision. And I found myself rambling on and on and on because they weren't going to interrupt me. They were waiting to hear everything I had to say before a decision was made. So it's important when you're trying to engage someone in a conversation to know what listening style they're going to be. Are they going to interrupt you? Are they going to ask questions? Are they going to let you move on? Are they more content and they're going to want to get all that information? Are they a people person? Are they going to focus on feelings, common interests, involved listening? Or are they just a time listener, that they're busy, they don't want to be interrupted, they hate ramblers, and they just want you to get to the point quickly. And so you need to know as you're going in trying to have a conversation, especially if it's a conversation that might be a bit conflict-oriented. They might have an opposing view. So much of what we say has absolutely nothing to do with the actual words we say. As we talked about, it's body language. It's conveying a differing opinion, but conveying a differing opinion in a way that isn't observed as defensive or combative is challenging, and especially if you're feeling defensive or combative when you're trying to present that opinion. But what's even worse is when a good point doesn't get made because you're afraid of appearing that way, and you don't want to be perceived as being disagreeable. So non-defensive communication is going to include speaking loudly and clearly so that what you meant to convey is understood, having the right verbal context, verbal savvy to articulate your words in the right context, and really, really watching that body language and your nonverbal cues. When we talk about developing successful relationships, 65% of your communication is nonverbal. And 38% of it is your tone of voice. So now we're looking at 93% of our message is communicated outside of the words we actually choose. So you need to keep in mind your body posture, your eye contact, your distance physical contact, your vocal tone, your inflection, your volume, your gestures, facial expression, even your clothing and accessories. I know I recently read an article talking about how you can tell when someone's unhappy with their job because of the way they start dressing. We're all looking to be assertive communicators. It's really the key to successful dialogue between parties. You want a non-judgmental description of what you want changed. Fully disclose how you feel, especially as we're working on our emotional intelligence and we're becoming aware of that. A clear impact and the effect on the other person's behavior on you, and a description of the behavior you desire. As these next two slides kind of talk a little bit more about non-defensive communication, responding by listening, waiting for anger to subside, offer support, provide alternatives to help make sure that the tone you're using really doesn't come across. The words you're saying, your opinion, your invested interest doesn't come across as defensive or an attack on someone. And I think that's really a challenge when we're looking at this patient-centered health home initiative and the changes that are going to come across. We're very passionate about how that's going to affect our stakeholders. And so trying to do that in an unpersonalized manner, putting yourself in the shoes of the other person, and really asking some questions to help find the best solution. So even with the best communication strategies at hand, there's no doubt conflict is going to exist on your team. Basically, conflict is when two or more people assume opposing and different positions in a situation or circumstance, and it's definitely going to happen. The expression of that difference can be verbal or nonverbal, overtly or covertly presented, and the conflict may be stemming from an experience long before your patient-centered health home team came together, or even with all of today's training, something that happened in the meeting. The reality is we aren't all going to be efficient, emotionally intelligent, active listeners, assertive communicators all of the time. I found this slide very interesting, and Judith Briles has some great references on conflict. But the staff thought that the management didn't know what they were doing, and management felt like there was too much change, which leads me to wonder if the managers didn't actually know what the goals and objectives were. And obviously, from the slide, they just weren't communicating it. And inherently, that does create conflict in your workplace. We've talked about making sure you're clearly communicating your action plan. You're managing your change in a way that works for your organization. Clear performance expectations should be communicated from the project sponsors to the project participants. Gaining consensus in early stages of the project is much easier than waiting until people have already invested time and resources going in the wrong direction. When you have people who have invested, worked really hard on a project, and then you take it out and someone disagrees, and maybe validly disagrees, and you really do need to make changes, the people who have worked so hard on that and have invested all their time are no doubt going to feel, deflated and attacked by the other person, and you're going to create conflict. So it's important for everyone to know the objective, know what's driving it and why it's important, and really doing your best to get that feedback from the very beginning. We have so many different sources of conflicts. We're all going to see the facts differently. We're all going to handle things differently. We go about our goals in different ways, and we have different values and priorities. So you need to pay attention to your feelings on your teams, perceive what's going on. If you feel internally that there's distrust, negativity, there most likely is. And how are you going to use your patient-centered health home team to manage this, and how is it going to affect it? We're talking about now some tips on addressing conflict and how to get two people together to address that conflict head on. As a patient-centered health home team, conflict is going to be apparent within your organization. Like we talked about, it might be stuff that happened before, it might be stuff that happens during, it might be inherent because you're changing somebody's workflow and they don't think that that's the best way to change it. And you need to, keep your overall goals and objectives in mind, make sure you continue to communicate those, and then really decide what you're going to do. Is the conflict at hand something that's affecting your team? And if so, how are you going to address it? Are you going to try and create a resolution? Are you going to deal with it? And what is the best way to deal with it? And I know a lot of people use their patient-centered health home coaches to kind of get some advice along these lines. Like, have you noticed that Sally and John really don't like each other and they're not communicating well in our meetings? Again, we're talking about action-oriented leadership. We need to get this team moving forward and taking the actions necessary. So can they work together? Can they both be on the same team? And how do you engage them in actions that perhaps they don't have to interact with each other in the least conflict-oriented way to keep everything moving slowly and moving ahead to get the actions that we need to. So as we reach our last slide here, avoiding conflict and chaos. In closing, be aware that it exists and that it should definitely be in capital letters, because I'm not just referring that conflict exists. I'm referring to all the contributing factors we've talked about today that are going to make your patient-centered health home teams unique. The limited time of your staff, of your team members, the inherent, you have a multidisciplinary team, so everyone's going to have different levels of interest, competing interests. You may be talking about something that's really great for one department but is really going to be a problem on another department. It's going to create more work for this group or this group, and there's going to be that inherent conflict built into your teams and how you're going to deal with that. And we've talked about, your emotional intelligence, knowing each other's personalities, being emotionally intelligent, using your good communication and listening skills to make sure everything is going well. And you do have to know that your conflict is going to exist. And work with others to embrace the change. Get your change leaders out there. Get them excited. Find your easy targets and get them going. And again, we talked about with our EHR example, start with the low-hanging fruit. Start with some examples. I know one of our things with patient-centered health home was printing our patient summaries. And it's a simple button. It's a simple click on the bottom of the screen that most of our providers didn't even know it was there. So it was really nice because you could go in and say, hey, you're at 12% of your patients receiving patient summaries. Did you know this button's here? And we're just going to have your MA click this at the end of the visit, and it'll give them their patient summaries. And a week later we went back and said, oh, wow, great job. Look, you did it 80% of the time. And so we had those small successes for things that are easy to implement versus the bigger changes that are going to take an entire, redesign of a workflow. You want to get people excited in the beginning. Be sure your stakeholders are on board. Everyone needs to know the plan. You definitely want everyone to know what's going on, what you're doing, why you're doing it, the objectives that we're trying to meet. Dwight D. Eisenhower said that leadership is the art of getting someone else to do something you want done because he wants to do it. And so I'm hoping that the tools given in today's webinar helps you bring your patient-centered health home teams into actions and they're getting things done, not just because NCQA wants them to do it, but because they want to do it. Thank you.